Hello and welcome back to the Q Aligners course. So in this section we're going to talk about IPR and attachments. IPR means interproximal reduction, and it's changing the shape of the tooth, the shape and the size of the tooth, whereas attachments relate to little composite attachments which are temporarily placed on the teeth to aid tooth movements. So IPR is used predominantly in crowded cases where we want to align the teeth and only a little bit of room is actually required in order to do this. Attachments let the aligners grip onto the teeth more effectively, and they also improve the retention of the aligner, improving patient comfort and ultimately improving the way the teeth track and the treatment outcome as well. So IPR stands for interproximal reduction, and in this talk we're going to talk about how your IPR is planned, so all the components that need to go into effective treatment planning for your IPR. We'll talk about what you need to convey clinically to the lab in order to come up with your ideal treatment plan, and how to carry out the IPR once you know how much to do and where to do it. We'll then talk about real-life problems that you can have with IPR, how to minimize these, and how to ensure you get the IPR done in exactly the right places at the right amount of time and maintain tooth morphology. So when you're planning on how much IPR to do, it's important to understand that it's unrealistic for you to know exactly how much IPR is needed at the beginning of treatment just by looking at the patient clinically. In order to have all of the information, you do need to send the impressions to the lab. The lab will pour the impressions up and do a setup, and you can come to an agreed treatment plan together. So it's critical that the lab has good quality impressions and good quality photographs to go along with the case. They will then pour up your silicon impressions and scan them into a computer, and then from that they can do an ideal digital setup, and that will give you a very accurate idea of how much IPR is needed and on which tooth surfaces as well. But this isn't the full picture. We can't rely on the 3D setup. So really what happens is we have information clinically relating to how much the teeth can actually be proclined, the relationship to the lower lip, the actual shape of the teeth, whether they're triangular, square, things like this, which we'll go through in a minute, are important in planning IPR. In addition to this, the lab will then do everything that we've just discussed. They'll do the space analysis, and then through effective communication with yourself and the lab, so you'll be able to come up with the ideal treatment plan, knowing how much IPR to do and in what areas to get the best results for your patient. So it's important to realise that we shouldn't rely 100% on IPR to achieve the alignment we need to in our cases. We can get a lot of space just by looking at the position of the teeth right now and considering arch expansion. So arch expansion is something that we use all the time in fixed orthodontics, and it essentially means we're proclining the retroclined teeth and creating space that way. So the advantage of this method is that it is non-destructive. We're not actually removing any tooth surface away. So as we're all trying to do minimally invasive dentistry, this fits in very well with our work ethics. The next thing is it's really effective in the cases where we have retroclined teeth. So classically a Class 2 Division 2 where we have retroclined incisors, this way will work really well. So it will mean you rely less on IPR and still get outstanding results. So let's have a look at this case quickly. You can see it is a classic Class 2 Division 2 case. We have retroclined incisors and we have slightly proclined lateral incisors. If we look at the occlusal photograph here, you can see this quite clearly, that the centrals and one premolar are more retroclined than all of the other teeth. So it would make sense to procline these first, see how much space we get, and we may end up with an ideal result just by doing that, which is exactly what happened. So we can see here that in the final photographs that everything is well aligned. This case was done with no IPR at all, and the patient is very happy with the end result. Now it's important also to realise that this case shows the limitations of clear aligner treatment as well. On the left side we are still half a unit Class 2 at the molar and the canine, and the right side isn't perfect Class 1 either. If we were just treating the upper arch here, we would have an increased overjet as well, which is something we need to tell the patient about. But as this case was treated with upper and lower arch, the lower arch was also proclined slightly, and the increase in overjet was minimized. So let's have a look at the same case just from the occlusal photographs, and you can see if we were to draw a line of best fit here on the preoperative photograph, you can see that it's not a perfect arch. The front teeth do look a little bit more flat than they should. If we compare this to the same line that we draw on the case at the end of treatment, you can see that we've got a nice horseshoe kind of shape. Now, if we were going to superimpose one line over the other, you can see that the increased length of the red line indicates how much space we've actually gained just through arch expansion. So this is an important thing to consider when you are planning your case and understanding where you're going to get the space needed to align your teeth. Now, saying this, in crowded cases, we quite often do IPR, not just for space creation, but there are other reasons as well. For example, if we did no IPR, we could end up with teeth which are over-proclined, and this is a common thing that patients don't like to have, is teeth that flare out too much. In addition to this, relief of crowding often results in black triangles forming between teeth. So this is where the contact point between the teeth is far away from the gingival margin, leading to a black triangle. So in these cases, it's a good idea to do mild IPR just at the contact point and bring the teeth together and eliminate black triangles like that. So doing a mild amount of IPR at your review appointments will also free up the contact points, reducing collisions between teeth and ultimately ensuring your tooth movement is as smooth as possible. So what level of IPR should you be doing or should you be considering for your case? Well, obviously this depends a lot on the individual case. However, there are some guidelines which may swing you more towards arch expansion or more towards IPR. Let's have a look at a few of these now. So if you have teeth which are more triangular in shape, then we can rely more heavily on IPR because we know we're probably going to get more black triangles in those situations. So if we have a look at this case here, where we have these lower incisors, they are fairly triangular, and you can see that there are potential black triangles maybe between the central and the lateral here. So in this instance, it would be a good idea to consider a little bit of IPR here, because not only are we getting our space requirements to align the teeth, but also improving the tooth morphology and reducing black triangles, which is something that patients generally dislike. So in situations where the teeth are already proclined, or if we were to procline them further, it would actually detract from the aesthetics of the smile, we then need to rely more heavily on IPR, and we can't rely at all on any arch expansion in those situations. We should also keep an eye out for existing restorations. It's much more preferential to reduce a tooth restoration than it is natural tooth. So let's have a look at another case. So in this situation, the gentleman came in and he didn't like the appearance of his canines and he wanted those straightened out. Now, you can see from the preoperative photographs that the teeth are already a little bit proclined. This didn't bother him, but we knew that we couldn't procline them any further as this would look bad. So here's a close-up of the front teeth, and you can see a number of other things at this stage as well. Namely that we do have a black triangle between the front two teeth. The teeth are a little bit triangular in shape, and the front two teeth are not symmetrical either. From the occlusal photograph, you can see how much space that we do need, and you can see that this upper left canine needs quite a lot of space, maybe 2 or 3 millimeters all in all, to align the teeth and not get any further proclination. So in a case like this, because we cannot rely on any arch expansion, we do need to rely more heavily on IPR. And this is because the teeth can't be proclined any more than they are. They are triangular in shape, and because we have this black triangle in the middle and between the centrals and the laterals as well, we can improve the tooth shape and eliminate the black triangles with IPR. So that's a good indication for doing IPR. Unfortunately, we don't have any anterior restoration, so anything that we do reduce will be on natural tooth surface. And the height-width ratio of the front two teeth can be improved. So let's take a little bit of a closer look at what I mean by height-width ratio. When we're looking at smile design principles, we want the width of the tooth to be about 75 to 80% of the height of the tooth. And you can see that, especially on the left side here, the tooth looks a little bit boxy. It's more square than it is rectangular. So this means we can improve the appearance of this tooth. By doing a little bit of IPR, we can actually slenderize it and improve the height-width ratio. The right side tooth actually looks okay, but we don't have symmetry between the two teeth. So at the end of treatment, we're likely to need to do a little bit of enamel contouring just to level out the incisal edges so that the full smile does look really nice. So here we can see the black triangle here between the teeth, but quite often black triangles are not visible. Let's look at this case, for example. You can see that we have, again, a poor height-width ratio. The width of these central incisors is quite wide. In addition to this, we can see that the teeth are quite triangular in shape. So at the incisal edge, they're much wider than they are at the cervical margins. And we can see this by drawing lines on the teeth just to accentuate the appearance of them. You can see how triangular they actually are. So we can't rely on any arch expansion, any proclination of the teeth because they're already in an ideal position. So in this case, again, we're going to rely more heavily on the IPR. We're going to specify that we want the distal edges of both the centrals to be the areas where we focus our IPR in order to improve the height-width ratio of the teeth and gain space to align all of the teeth as well. So when we're deciding on how much arch expansion we can actually rely on, there's a few things to take into account. So we need to really understand how proclined or retroclined the front teeth are. And the ideal situation is to have the teeth at 90 degrees to the occlusal plane. So this means when you're sat in front of the patient, you're looking at the patient, you're having a conversation, the facial plane of the front teeth should be at 90 degrees. You should be seeing it straight on. Another guideline which is sometimes useful is to look at the relationship between the upper incisors and the lower lip. So I'll quite often ask my patients to say the F sound and look at the relationship of the incisal edges of the upper teeth with the lower lip. So in an ideal situation, I'd like the incisal edges of the upper teeth to be sitting at the wet-dry border of the lower lip when the patient says the F sound. Now remember, if you have a skeletal 2 relationship, you're unlikely to get this incisal edge to lower lip relationship. And again, in skeletal class 3 relationships, the incisal edge to lower lip border is going to be different as well. So this is only really useful in skeletal 1 cases and very mild 2 and very mild 3 cases as well. And realistically, you should be taking all of this information into account and deciding on what the ideal treatment plan for that patient is. So right now you may be thinking there's a lot of things that we're looking at here which you may not routinely be looking at, and how do you know how much IPR to do and how much arch expansion to rely on? Well, the good thing is the lab is quite well versed into looking at cases with these guidelines in mind. Obviously they can't look at soft tissue relationships with hard tissue relationships just on models, but that's where photographs come in useful as well. And it's always a good idea to have 2 sets of eyes looking at a case rather than just you on your own. Ultimately, the decision on what to do and IPR, where to do the IPR is ultimately yours, but you can get advice from multiple sources. So we have the lab who can provide you a little bit of advice. And we also have an online forum where you can post your cases and get advice from Q mentors who are highly experienced dentists or specialist orthodontists. But one thing I would say is don't rely 100% on the digital setup, because this is only part of the information you need in order to make the right decisions for your patients. So now let's look at IPR and how to carry out IPR effectively and safely. So IPR strips, like we've got in this photograph here, are extremely safe and easy to use. They come in different width sizes, so you know how much IPR you're doing at each appointment. This helps you keep accurate records, and it's important to keep accurate records of your IPR, because as the treatment progresses and you do IPR at multiple stages in the treatment, you may inadvertently be doing extra IPR on individual teeth as you're trying to relieve crowding in one specific area. So if you've got accurate records, you'll be able to keep up to date on how much IPR you've done and ensure that you don't over IPR any tooth surfaces. When you're doing IPR, it's always a good idea to keep tooth morphology in mind. If all you do is use these IPR strips to make space, you're going to end up with very flat contact points. It's important to curve the edges of the teeth as well, maintain the line angles of the teeth, and therefore it will look like you haven't done any IPR at all. So here's a diagram of 4 lower incisors, let's say, and quite often the way IPR is advised is you take a strip like this. We know the width of this strip, in this case it's 0.2 millimeters. It's a double-sided strip, so when this strip becomes free, when you're passing it between the contact points and there's no resistance, you know that you have 0.2 millimeters of space between those 2 teeth. And it's reasonable to think that 0.1 millimeters came from one tooth and 0.1 came from the other tooth. However, it's not always this simple. This is a diagram of a typical scenario. Your patients come in without straight teeth quite often. So here, if we were to use the same technique and use an IPR strip, then it would go in between the teeth like this. And when you apply the pressure, the forward-back pressure, you would end up getting IPR in these areas. Now, the problem is, this is not where the IPR has been prescribed, and although when you're moving it to and fro, you will get that 0.2 millimeters of separation, you're actually getting it in the wrong place. So, where we actually want the IPR to happen is at these points here. When you have your IPR prescription, it's actually relating to the reduction in the medial-distal width of the tooth, not just where you can get your IPR strip in. So in situations like this, where you've got visible contact points, it's often easier to use a composite polishing system, maybe a soft flex disc system, to adjust the contact points. The downside of this system is sometimes it's difficult to note down exactly how much IPR you've done. So it's a good idea to take detailed photographs every single stage when you do your IPR as well. And with a bit of experience, you can write down how much you estimate the IPR that you've done was. So really, when we've got crowded cases with just mild amount of crowding, you rely more heavily on the IPR strips. It's much safer, it's easier, it's easy to write down exactly how much IPR you've done and therefore keep accurate records. So here, where the blue lines are, would be ideal places to use the strips and get the space using the IPR strips like we mentioned. When you've got a contact point which is completely visible, like on this lower right 3, it's easier to use a coarse polishing disc to adjust the contact points of that tooth rather than using a strip. So when you do this, it's a good idea to use a full series of the soft flex discs, because this will give you a much more polished enamel surface once you've finished, reducing any chances of any friction between the teeth, but it also is a much better way to leave the tooth, because a smooth surface is much more protected against caries as well. So in reality, even in a case like this, we would actually use a combination of the polishing discs and the IPR strips. So you can see between some of the incisors, it would be quite easy to use an IPR strip in those situations. Obviously in this case, the patient does need to see the hygienist before starting any orthodontic treatment. So now let's look at placing attachments. So attachments are used for a number of reasons, but the most important reasons are to get a better mechanical lock between the aligner and the tooth itself. So this will improve the effectiveness of your aligners, and it will let you carry out certain tooth movements which are almost impossible without attachments. In addition to this, it's also going to improve the retention of the aligner in the patient's mouth. Now, the process of placing the attachments is actually very simple, and we're just going to use etch, bond and composite like you have done many times in your restorative dentistry. And we'll supply you with a matrix to give you the exact shape and size position of all of these attachments. So the process of actually placing these attachments is very simple. I'll go through it step by step, but you should be familiar with most of these points here. The first thing we need to do is etch, dry and bond the tooth surface where the attachments are. So when you get the attachment matrix, you'll be able to see where on the tooth this matrix is, so just apply the etch and bond in those areas. So the next thing to do is to fill the matrix with the composite flow, and it's a good idea to use a highly filled composite such as the tetric flow. So when you have composite materials, there's two parts to them. There's the filler and then there's the resin. The filler is the hard stuff, the resin is effectively the glue that keeps all the hard stuff together. So if you have a high filler content, the composite is much less likely to wear during treatment and as you're placing and removing the aligners. And then we seat the whole thing down onto the tooth. So the composite flow is in the matrix and we've prepared the tooth surface on the tooth. We then place the matrix over the tooth, ensuring that the fit is exactly as it is on the model and there's no separation between the tooth and the tray. Then we light cure it for 40 seconds and then remove the matrix off the tooth again. So once the attachment is on the tooth and you've removed the matrix from the tooth, it's a good idea just to go around the edges and remove any flash of the flowable from around the attachment. Be careful not to actually damage the attachments when you're doing this. You need to then double check that the patient can place and remove the aligners by themselves. Remember that the retention of these aligners dramatically increases as soon as we put attachments on the teeth. And it's a good idea to keep the attachment matrix with you or with the patient's lab work until they've reached the end of treatment.